Thank you so much, Antonia, and thanks to all of you for joining. So I live down the street, and when Antonia asked me if I would come and talk to you all, the topic of how libraries can contribute to responses to the overdose crisis, really came to the forefront. And so my job today will just be to set the stage for Leanne and Ashley because their project is super cool and focuses on how libraries can be a platform for harm reduction and treatment access, which is a really important innovation and uses the library in a very innovative way. So let's see. So with that, I wanted to just briefly talk about where we are. You know, obviously the overdose crisis is an issue that probably doesn't need much of an introduction. You all are aware it touches so many folks in our nation, but also especially on the Cape where overdose rates are higher than the state average. I'll talk a little bit about sort of why the crisis has evolved as it has. Talk about the role of local innovations that a lot of the major responses that have worked over time actually started in Massachusetts. So I'm going to highlight a couple of those responses and then kind of set the stage for Leanne and Ashley's presentation about their work. Hey, come on in. So as I mentioned, you know, the fact that we're in the midst of a crisis that's now in its third decade is not new to any of you. I see some first responders here in the audience. You know, obviously it's been a burden on many levels, including on our frontline first responder personnel, which is kind of another area of research that I do, and I won't talk much about that. But the thing that I wanted to highlight, there's many things that we can talk about, but what I wanted to highlight is that the crisis has sort of morphed and changed over time. We started out around the turn of the century with the wave, what people call wave one of the crisis, that was driven primarily by prescription opioids, which then shifted into a crisis driven by overdoses involving heroin, and then more recently to overdoses involving synthetic opioids, primarily fentanyl, but also other kinds of fentanyl analogs, as well as illicit stimulants. And so as this progression has unrolled, the local communities have really led the way with innovative responses, as I will talk about later. Pretty much from the beginning, this crisis really wasn't, you know, sometimes people call it the opioid epidemic or the opioid crisis. And that's somewhat true because a lot of the deaths involve opioids, but a lot of the deaths also involve other drugs like benzodiazepines, alcohol, stimulants. And so in some ways, you know, just focusing on opioids misses a larger picture, which is that there's a lot of substance use in our communities. People are using all kinds of substances, they mix them together, and there's a much more complex picture in play than just focusing on opioids. It is also important to note that the crisis really didn't start out in 1999 or 2000, as some people claim, because overdose rates have started to increase way before that. And so we're really in the midst of a multi-year, multi-decade crisis in substance use. It's also, just to complicate the picture even more, it's also true that rates of other chronic conditions are increasing. And this has been actually in news a lot because the current federal administration is really focused on sort of chronic health issues. And it is true that poisonings, which overdoses are on the rise, but there's also a major rise in chronic liver disease, which is associated with alcohol use, suicide, and other issues where, again, it is symptomatic of pretty complex underlying problems. So in thinking about why this crisis has evolved as it has, it's useful to note that a lot of times when you talk to people about why they're using substances, illicit substances and prescription drugs non-medically, meaning they're not using them as prescribed, they will note that they're using them as a form of self-medication. So because of various structural problems accessing care for a variety of health needs, people use these substances for pain control, but also for mental health needs and other kinds of conditions. And this is, somewhat of a different viewpoint. I think it's useful to highlight this because a lot of times folks assume that people use opioids primarily non-medically, so outside of the healthcare system, primarily kind of as a party or to have fun, and that is I think that will be somewhat of a different issue than what we have, which is that folks are using primarily to self-medicate. This is an interesting graph because it turns out that in America, people actually report being in major physical pain more often than in other countries, and we don't really understand why. Is it that folks are working, in occupationally risky ways that result in a lot of workplace injury? Is it a lifestyle thing? Is it related to diet and exercise? Or as some people note, it's also there's a lot of differences in the ways people talk about pain in different cultures. So like some cultures you're expected to just kind of tough it out, and some cultures you're expecting to have it solved by the healthcare system. And maybe it's part of the question or part of the reason is that folks in the United States are just like more willing to talk about pain and expect it to be taken care of with a medical intervention. This is just there's not an answer here, but it is an interesting sort of question of why people report pain a lot more frequently than a lot of other countries. So one of the key sort of questions about the way the crisis has evolved was that in the context of the first wave of this pattern in terms of rising overdoses, there was a really concerted effort to restrict access to prescription drugs because the first wave, as it talks about, of the crisis was the first wave of the crisis was driven by prescription medications. And so the assumption was that if you restrict access to prescription medications and reduce overprescribing, reduce the number of pills that are out there, shut down pill mills, that this would address, rates of overdose. A lot of these policies and interventions focused on, kind of turning off the faucet of opioid medications, which was, wide open for quite some time. Unfortunately, and this really happened around the time of the transition from prescription drugs to heroin as a driver of the crisis, as the number of overdose deaths involving, as the number of opioid medication prescriptions declined, the overdose rates went up. And this was kind of an unexpected result because, again, these policies and all these different efforts to restrict access to medications was expected to produce the opposite. You know, the idea was that these graphs were going to sort of be collinear, like they would decline in unison, but in fact, they became sort of a mirror image of each other. And so this really helps to highlight that, you know, there's kind of this underlying situation where a lot of people are in pain, both individually, but also in terms of economic pain. You know, thinking about like Americans experiencing the mortgage crisis around 2008 and all kinds of issues with deindustrialization and a lot of other kind of societal structural problems. That really highlights that the problem is a lot more complex, which I guess is a kind of an underlying theme that, you know, restricting access to pain medications really resulted in the opposite effect. And we're continuing to see that sort of developing and evolving over time now. I guess, you know, on the hopeful note, there has been a lot of local innovation that has helped to address the crisis. And that is why we've seen since around 2023, actually a decline in overdose rates for the first time since the crisis started. So we've seen both locally and on the state level and nationally that overdose rates have declined by double digits in a lot of places. And one of the real drivers of this decline has been access to naloxone and access to substance use treatment and other responses that really were pioneered by localities. So just to, you know, kind of situate again this local innovation, naloxone distribution started in various pockets around the country, Chicago, New York, but Massachusetts was really a pioneer in getting naloxone into a lot of hands, both to first responders, including law enforcement, and as well as getting naloxone into the community, so in the hands of as many people as possible. And the kind of the innovation evolved in the first decade of the century, like around 2008, 2009, 2010 is when Massachusetts opened or issued a standing order so that even though naloxone was available only by prescription, there was essentially like a standing order, a prescription for the entire state. And it produced really, really great results, but as you see here, you know, access to naloxone really didn't ramp up until very, very recently. So this just shows you, this is data from Rhode Island, that, you know, up until 2018, 2019, access to naloxone was actually pretty low. And so, you know, people have asked why we're seeing these declines, you know, after many years of increases, why we're seeing declines now. And it's really because local innovation was finally able to scale up to the population level. And as I show here, this is just a description of some of the other like local innovations, and in many places around Massachusetts, access to these innovations remains pretty low. Just you know, kind of wrapping up this background, one of the other structural issues that we've seen in the context of the overdose crisis is the loss of what people call third places, and this is a concept around like places of connection around a community. You know, a lot of times people say, this is, I think, a quote from Robert Mate, who's an addiction researcher and a writer, that the opposite of addiction is not sobriety, but the opposite of addiction is connection. And the fact that we are increasingly isolated and there's not places that people can interact and gather and sort of form meaningful relationships and find a way to occupy their time and find meaning in their lives. This is something that has been linked um, uh, in some cases by research to the lack of this like gathering places. So, sometimes these are libraries, sometimes these are coffee shops, town squares, like other kinds of places that have become increasingly privatized and commercialized, and you have to pay to participate in these kinds of structures. Libraries kind of buck this trend, and they've become a really important anchor for a lot of communities in thinking about how to respond to community challenges, whether that be housing. A lot of libraries are struggling with serving people who are unhoused. There's just not places that people can go for shelter. There's things like the digital divide, where libraries are providing access to information online, as well as obviously through books. There's a lot of places have a lack of services that are provided for free, and just general kind of care for people who are marginalized. And so in response to the overdose crisis, there's been local innovation around using libraries as a platform to reach people. This idea of meeting people where they are, quite literally, not just conceptually, but quite literally going to people where people gather, and creating co-locating services within libraries to address this kind of marginalization and needs that people have that are not being met by other third places, because those are disappearing. And so at this point, I'm going to just stop here and turn it over to my colleagues from San Diego, because they're going to talk about a really cool project where they're using the library as, again, a platform for reaching folks who are at risk of overdose. And let me see, I don't know, Ravi, do you want to pull up how do you want to, are they
I'll go ahead and share screen mine. Is that okay?
Yeah, if you share your screen, that would be great. Okay.
Okay, hello everybody. Thank you for inviting us. Thank you, Leo. So I also have Ashley Whitensteiner, who's a doctoral student, who will be presenting this with me as well. So we have a wonderful, innovative partnership with our public library system here in San Diego, as well as with our federally qualified healthcare clinic. But I wanted to start with just how did we even start this partnership to begin with as a researcher in a school of social work? So honestly, I came across another parent who was a librarian in our downtown library, which is 9 floors, 2 floors is a high school. But she was getting out of there because she said there was so much opioid overdose going on in the bathrooms and mental health crises every single day. But she was moving to another smaller library, and she welcomed me, though, however, getting excited about it, as opposed to her. And she welcomed me forming a partnership, and she introduced me to the head librarian there, who was fairly new. She had moved from across the country, and she also was alarmed at what's going on in the library. So I also introduced a colleague, and we thought, why don't we have a social worker internship in the library, start that first, because have experience doing that in the past. And so while setting that up, we also talked about how about some research, because the library was really interested in just knowing what exactly was going on with this opioid crisis, because they really didn't know the extent of it. They just saw what's happening inside and right outside of their doors, but they really wanted to hear more from the library patrons what was going on with them. So this 9-floor library, this was right before the pandemic, there were 3,000 people entering the library every day. That still happens, at least 1,000 entering every single day. And around 300 are estimated to be unstably housed and staying on the certain floors of the library. At the library, as you know, I'm speaking to the choir, is really a welcoming space for the public. And so this really helps patrons who can't connect their internet, they don't have phones sometimes, and they're able to avail of all the services there, including employment offices and things in the library. We now have a hub for homelessness that moved from outside the library into this library. So more than ever, it's a place where they could get some help and connection and services. Connection, as Leo says. Right before the pandemic, they actually experienced their first completed suicide indoors. So that was really alarming. Somebody fell off or jumped off the second floor and right into the lobby where, the other patrons and the librarians were really traumatized by that. They also had an overdose in 2021 that was due to the drug overdose, a death in the bathroom. So while there's been deaths and revivals that the security has done outside the library, this was one of the first where somebody actually died, and they've revived many in the bathrooms as well. So we, launched this research partnership. This was before we even did our telehealth intervention around treatment for opioids. We already were getting a lot of coverage just from trying to come up with solutions with the library around social work and social work interns. So how we did the initial assessment, we actually co-created it with the librarian, with the head librarian and some of the staff. We came up with just a brief one-page questionnaire, but then we actually did in-depth interviews. And the goals were really aligned with the vision of the library to be a place for opportunity, discovery, and inspiration. And they really wanted to know what were the educational needs and barriers the patrons were experiencing, what were the training needs of the librarians, and what kind of policy changes are needed in the community and maybe also in the library. And so we interviewed at least 30 of the library patrons in depth, and then also 10 library staff. We also had a brief survey, also an online anonymous one with the library staff. So altogether there were 63, because we also did some focus groups. There were 3 focus groups, and one of them, we recruited those who were using opioids right outside the library. They came in and we did this focus group, and that is really where we realized that people were overdosing much more often than even the library thought. The library thought it was maybe once a month that they were experiencing it within their walls, but they were saying it was happening every day, right? And then we also did a couple of other focus groups focused on women, and so. But with that focus group and the opioid crisis that we were hearing a lot about, we launched this pilot randomized controlled trial in the library. So with this one, we were able to apply for NIH federal funding, so National Institute on Health, National Institute on Drug Abuse. They were really excited by the innovation of this because they said, this is a no-brainer. The public libraries are here, the people are in the libraries, and this is even a low-cost kind of effort that can be done, where we set up telehealth, a iPad on a stand, kind of it was locked in the stand. And patrons can come in and talk to the medical providers and get prescriptions for buprenorphine treatment, which is for opioids. And then they can follow up on telehealth. Now, this particular Father Joe's Village's federally qualified healthcare center, the medical providers did want to see them for their first visit. So while we had close to 200 that we screened, we got 60 who actually made it to the first medical visit, and then we randomized them to either doing telehealth in the library or that they kept going in person to Father Joe's Villages. But all 60, they came back to the library every week for 12 weeks. We followed up with them. And so the main thing we did was to know about this is that we recruited them outside, inside the library with flyers. We didn't approach them in the libraries unless the social work intern was able to, but people can come up to the front desk and see the flyer. They were also sometimes able to sign up for it, either at a table or at the front desk. or they just saw the flyer in the library and they saw us there in the library and they came over to us in our private meeting rooms, which all has glass around them so they could see us. And so they would come both from whether they're in the telehealth group or the control group. We followed up with them there in the library. We did the urine testing. It's just a self-test. They could pee in the cup and take a self-test and then just bring the results back to us. So they did use the library bathrooms. We had an oral test at first, but it wasn't as reliable. And they were just so used to, they were just fine with doing the urine test. So it really wasn't a big deal that we, were a little worried about at first. And then we also did a survey with them, both baseline and follow up with them every week for the 12 weeks to see if they were still on the medication. So this urinary screening would look for drugs, but also if the medication was in their urine. And it was all for research. There was no consequences. So I'm going to have Ashley talk about our results.
Yes, thank you. I'm excited to have been involved in this, and there were some exciting results that we saw, some good success markers. People who use telehealth were much more likely to stick with treatment. So they were about 2.5 times more likely to take their medication and 2 times more likely to see a medical provider more than once versus the control group. Most people in the telehealth group picked up their prescriptions multiple times, 71%, while in the control group, we only saw about 21% pick up their medications. So that's good for treatment adherence. And then we also used like Dr. Urata said, urinary drug screenings. These also showed that people were taking their medication like they reported, and they were cutting back on their substance use. We saw a lot of positive changes reported. Over 1/3 said they cut down on drug use, and that means that 36% recorded a decrease in days that they used drugs, whether that be prescription misuse or illegal drugs. Nearly 1/4 of them cut down on their opioid use. So specifically cut down on opioid use days, with most of those people reporting a decrease in use of opioids being in the telehealth group, about 60%. And then nearly 1/3 of them said they had fewer cravings of fentanyl or meth. And again, about 3/4 of those who did report a decrease in cravings were in the library telehealth group. So we saw a lot of good signs, a lot of success markers.
Thank you, Ashley. So this was not without a lot of effort, even though it was pretty cost effective, because both the library and the clinic, they didn't want to do that much more business as usual in terms of their effort and time, because they wanted it to be sustainable. So they also didn't want to take much funding. They wanted this to be sustainable, regardless if even the research team was there. But it did still require a lot of rigor and a lot of people involved and a lot of students involved. It's not without its challenges. I wouldn't say it's just really easy. You just put in the telehealth on an iPad and just let it roll. As Leo was talking about, there's a lot of people dealing with trauma and just a lot of barriers, whether it's not having an ID, so having trouble picking up their prescriptions, or transportation, although we gave them some of that help, but just fear of taking the medication, or just, like I said, going to that first visit, but also not having a telephone. Sometimes some medical providers may require that they have a way to reach them before doing the telehealth. So, so we and library staff being available makes it easier, although technically they could just go and do it on their own. So we welcome any kind of questions. Maybe you have questions about how to implement this. We are waiting to do a larger trial that would be more, 200 people in one library. We did this in 2 libraries, but we've proposed to do it again in the big library with 200, and we're waiting on the outcome of those results, of that funding outcome next month. So we'll stop share.
Thank you so much, Leah and Ashley. Really exciting to see these outcomes. And when I first heard you talking about this project, it was just like you said, it's just a no-brainer because the folks are already there and the infrastructure is there, and it's just kind of a natural fit. I had a question before we kind of turn it over to the audience. So can you clarify as far as the telemedicine piece of this? So folks would have an appointment and they would get a prescription issued, and then they would need to travel to a pharmacy of their choice to pick it up, or how would that work?
Right. So typically, almost everyone used the same pharmacy. It was a CVS pharmacy or Allen Pharmacy in San Diego. Those were the 2 main ones that Father Joe's Villages, the health center, they wanted to use, and that the patients tended to either agree with, or they wanted to use it, or they've been using it. So we tried to keep it so that it wasn't a lot of pharmacies, and that's why we kept it with just one health center, and it tended to be just the 1 or 2 pharmacies. So Father Joe's Villages didn't want to deviate too much from business as usual, so that is how they usually do it. They do give them the choice, but they usually use those same pharmacies. In retrospect, I probably would try harder to have more of a relationship with the pharmacies to reduce some of these barriers about having an ID. It's just that I know, because this is a controlled substance, they can be really sticklers about it. On the other hand, sometimes patients had more success than others with getting it when they had troubles with their ID. So that's what I might do differently.
What was like the attrition rate in terms of folks who got prescriptions but never picked them up? Did you track that?
We do have all of that information, but actually I haven't really looked at that. So now that you are bringing that up, that's a great idea. I know some, they had to try for many weeks and then finally got it, or they struggled for a couple weeks and then got it. But in terms of like never getting it, sometimes it's hard to tell because we didn't stop people from coming the 12 weeks if they never got their prescription. We did stop if they didn't ever go to the doctor in the first visit. But if some kept saying they didn't get it, sometimes there were some who just really maybe didn't want to take the medication, but the majority, took it. And there's a couple questions in the chat, so.
Yeah, I don't know, do you want to just read them
Sure.
out loud? Because folks in the audience here can't see that.
Okay, it says, how do you think this could work in more rural areas such as Cape Cod? So we did have a smaller library that was, I wouldn't call it rural, but it was farther away from the health center, substantially farther away, that it did create a little more barrier for them going in person. I would say there are medical providers who don't require the in-person visit for the first visit. It's because there's federal laws that are, that change, and I think they do want at least a visit, but it doesn't have to be the initial visit, I believe. So that might help reduce the barriers if that in-person visit wasn't required. It might actually help enhance the importance of having telehealth more. So I would say find a provider that maybe is less strict about that in-person visit. They may still have to go in for some urine testing because in the urine screening, because during the pandemic, that's what they had to do, but it's usually not that often. So I think it definitely is even more important for rural areas and areas where people have trouble seeing the doctor. That would be the whole point. In this case, it wasn't that far. They can actually even walk to the health center, but so many have barriers that where they can't even tolerate sitting in the waiting room. So we've had those, or just the atmosphere. What was the reaction of the general public that utilizes the library, particularly families with young children? Yes, so we did some of that work before proposing it or in our application for the pilot. And there were some quotes from families where they say that, well, basically they think it can be discreet, so they don't need to, see it happening, and that they just thought it was a need, because what they do see now is what they don't want to see. So if this will help that situation, then they welcomed it, because they were more concerned about the privacy for those individuals, not so much about them being a threat, because right now they're already in the library. So, having less needles in the book stacks would be better to addressing this problem. And then of course, even in the small library and the big library, there was enough spaces in these libraries to have where it wasn't, when we actually did the project, it wasn't affecting families and children. They usually didn't even know that it was happening. Even when we had a table like right in front, sometimes the kids would come up because they saw we had snacks. So they would take it and ask about it, but they never interacted. It's just like with these patrons, or people who are homeless, people often have misconceptions that they're unruly and they're violent, but for the most part, you can't even tell when someone is homeless a lot of times. Even these who are using opioids, most of the time they're quite quiet and trying to be discreet as well. So are there small ways to implement pieces of a program like this? We're on an island with limited access and resources. So I think that's the point, is for us to do it in a way that was sustainable and took little resources, including the time for library staff. I mean, technically library staff, they just need to let someone into the room if it's in a private space, or initially without, they can just check out the laptop and use that for the telehealth. But then we had this Mobex company who donated these iPads on a stand, which I think is even more helpful. So I think, I think it doesn't take any extra resources. There are libraries doing telemedicine, so it's really the same notion to having telemedicine available. You just might need to help the patrons more if they have barriers to using technology and navigating, their appointments. By the way, we did have this clinic was low barrier, which was great. So they let them do drop-ins, so they didn't have to have an exact appointment time. So sometimes there's a window like that whole afternoon or that whole morning. If they did have an appointment, they missed it, they can still be seen during that time period. But it does take a lot of patience sometimes to, wait, because you have to wait then for the doctor. So we were, it helps if someone's talking to them, keeping them occupied while they're waiting. Did the clinic only treat substance use, or were providers addressing a range of medical issues? The clinic we used is federally qualified healthcare center, which they treat a range of issues, so not just substance use. But in our telehealth intervention, it was just for opioids. And so it was just buprenorphine medication, because that's the one. It's also called, the brand name is Suboxone, or now there's injectable Sublocade. So because that's how research is and science is, we have to narrow it down if we're testing something out. So of course we have a lot of people using meth, and there's a lot of other interventions that are needed that could follow the same model.
Cool. I had some other questions, but does anyone here have questions for Leanne or for Ashley?
I actually have one.
Ryan, can you hear?
Can you hear
Yes.
me?
Yes.
Okay, so I actually have a lot of personal experience working for a local community health center that was one of the first MAT providers on Cape Cod. I was actually one of the first recovery support navigators for that health center, and I now work at the fire department, and I'm a social service provider at our local hospital. I was wondering if you stated a barrier, so I'm kind of giving you a layup here in a sense, that for like, when people didn't have IDs or couldn't access the medication. I know that was a huge barrier for us individually, but like I'm wondering if that local, health center has case management services in place, right? Like, so I know that our local one, I was a case manager for a lot of those patients, so I could access their medication for them when they couldn't, right? It like puts that wall down. We were allowed to get them cell phones. We were able to do all those things to pull those barriers down and allow them access to treatment. And I think my other main question was that the only form of treatment that was offered to these patients? Right, because there's multiple avenues to treatment. So in sometimes that can be a hurdle in itself, right? Someone could come initially for help and say, well, this sounds great, but this might actually be what I want to do. And I'm just curious because that could also open doors to other opportunities. And I also am an individual in long-term recovery, so I have lived experience. And now I'm on the other end and I'm able to help people in all facets of my life, really. But so I appreciate everything you've done because I do agree a big part of the battle is number one, meeting people where they're at and then also meeting them where they are, like you guys have done. The disease of addiction is, cunning, baffling, insidious, and it's rooted in fear, insecurity, low self-esteem, and isolation, right? So, taking those things out, and meeting people where they're at is a big part of the battle. So, thank you for your work. I just was wondering if that's something that is offered, because around here, I'll tell you right now, in our community, a lot of the people that we have in this position meet right over there in the green, right? It's right there. So, it'd be cool to see if I know that I can promise you that community health center would help you guys tremendously if this is something.
We already do something with
Excellent,
them,
yeah.
and when I'm about to rebuild, it's gonna take me a few years, but
Yeah.
when I have a new space, I plan on trying to have Duffy come and do some.
I've been fighting with I don't want to say fighting, but I'm a huge advocate, right, for like the people like myself and, with the shelter, it's tough because they don't want people to come, like the problem is like, oh, well, if you build it, they'll come. Well, no, sorry, they're already here.
Right.
Right, so let's help the people in our community and like having another place where that can happen is humongous.
Well, not only is.
So I love this idea.
So not only is the option of having telehealth help, but there's also so many other
Right.
forms of harm reduction.
Yeah,
Like we
absolutely.
can offer cultural programming,
Yep.
arts things, and Duffy does the mobile unit here. But if they end up coming into the space while people are waiting, they could watch a movie,
Absolutely.
they could have a book discussion group, they
Yep.
could just sit and look at magazines, whatever.
Right.
There's so many other options to create community and to engage,
Yeah,
so.
sorry, I didn't mean to go long on that. And the reason why I asked for case management and the big reason, because I still do this, is that you'll learn that there's so much more than just the drug use, right? Like the social determinants of health that people face on a daily basis, right? Is just, let's go to our needs, right? Like finding a place to stay, food, shelter, you know what I mean? Like connection to other supports in the community, all that stuff, just figuring those things out to live. And then, my brain will tell me one thing, it's survival. It's not, it's not it's hard to explain if you haven't lived it, but, yeah, I mean, I think that's a big part of it. And I really love this. This can be huge because we have a lot of libraries in Cape Cod, every town essentially, right?
Yep.
So, I mean, just having access to an option, and I will say from personal experience, I didn't know, when I was in active drug use or I've overdosed, I've been through, and now look at me, I saved people's lives, right? Doing what a medic did to me, saved my life. And, I didn't know you could get help. I didn't know that people went to treatment. I was, if you don't know what you don't know, you know what I mean? So and that's a big part too. We're offering education, we're offering options, we're giving people hey, you don't have to live like this. There are other options. Try it, meet them where they're at. They might say, hey, I'm not ready for that. Cool, but guess what you did? You seeded that, you planted the seed, so they go, oh, when I am ready, I know I can go there.
Yeah.
I think that's just really cool. So I'll be quiet, I'm sorry.
No, don't be sorry.
hearing you talk.
That's why we're here and yeah, thank you for sharing your story. Leanne, do you want to, or Ashley, do you want to talk about like any case management or other harm reduction? Like spillovers from the work that you did?
What was the last thing you said? I'm sorry.
Oh, the case
Like-
but I can go ahead, just,
Okay.
so,
Yeah.
so he was asking about, the case management specifically for being able to get the prescription medication from the pharmacy. I know that anybody with an ID can pick it up for somebody else. So we did realize that, but then we were kind of told not to do that, but maybe a case manager at the medical clinic
Right.
be the best.
Someone who works this.
Yeah.
Yeah, that's the only way we could do it, like, because we were the professional, like the healthcare professional, but, obviously liability, I understand that, like.
But I
And
think,
sometimes you said, like you said, working with the pharmacy, the other thing is too, like our pharmacy at the hospital, they know the patients, right? So like we'd always send them there because they're like, well, we've seen you over the years, we know it's you, you know what I mean?
Right.
We
Right.
also have that closeness, they're on the
Mhm.
green, they're in here, they can walk to the hospital,
Correct.
to Duffy.
Yep.
CVS right nearby. Yeah, so.
Yeah.
I like
So-
that because, okay, but anyway, yeah, I'm gonna take that thought back because I think that's true. They know, if they know they know the clinic, or if they know us, then maybe they'll trust that we know for sure this is someone who's a patient who has that prescription. So, let's see, and your other question, now I just blanked out what the other
I'm
question.
gonna go to another question in the audience, if that's okay. Yeah, go ahead.
Oh, okay,
So,
okay, thank you.
So this is kind of a more broad question about local solutions. So I'm a local family and divorce attorney, and substance abuse comes up a lot with custody. And I think some of the role that I would like to play, and hopefully other local attorneys would like to play, is actually educating the judges. Because depending on the judge may or may not even understand what these medications do, right? So if I have a client that's going to a methadone clinic or getting Suboxone, it's hard to know, is this a judge that understands this is actually a positive thing? Yes, it is a controlled substance, but it's someone working towards recovery. And so in terms of what maybe local attorneys could do to educate judges, because that to me is another really important role here. Like, I know we're talking medicine, but also the legal community needs to be educated. So I wasn't sure if there was any outreach that the three of you were familiar with, of just kind of educating judges, because you'd be surprised how much they don't know.
Yeah, I can take that one if that's okay. So the answer is yes. As part of my work at Northeastern, we actually have a judge education unit. I'd love to talk to you about it.
Yeah.
So Massachusetts actually has guidelines issued by the Supreme Judicial Court on substance use disorder. Judges oftentimes are not aware of that. And so what we've done is we are developing some education materials based on those, like, it's the court system itself that's created these standards, but people are just not aware. And like you said, a lot of times there's just a lot of lack of education and a lot of judges have their own sort of experience or their just preconceived notions about what it means to be in recovery. And so like, yeah, if people are on medication, there, a lot of times the determination is like, well, you're not clean and sober.
Right.
And yeah, I mean, technically the person is on medication, but they also could be on other chronic medications. And
Right.
so it's not necessarily an indication that someone can't parent, like people can parent
Right.
quite well on
The thing
various
that-
kinds
The
of.
thing that has come up a lot in these cases is if the judge is not familiar, right? Then you need to hire an expert witness,
Right.
and a lot of the clients can't afford that.
Yeah,
Right? So it's kind of like multi-barriers.
Yeah.
It's like, if the judge isn't familiar,
right.
it's like,
Yeah.
all right, who am I gonna get now to testify to this?
Totally,
Because
totally.
it should be common knowledge, I think.
Yeah.
But-
No, and
Yeah.
and yeah, I guess that's like rare piece of good news is like, yeah, there's like standards for the judicial system, and then I'm happy to share those with you.
Yeah.
And if you wanted to like maybe collaborate on organizing something for judges
Yeah,
in this area, and it's, yeah, like you said, it cuts across the board in terms of like criminal courts, custody stuff, civil law issues, all kinds of.
yeah, because it's weaponized all the time in custody battles,
Yeah.
all the time.
Yeah, absolutely, yeah. Any other questions, comments? Leanne and Ashley, in your study, was wondering if you could talk a little bit of, like, a lot of times people talk about diversion as like a major barrier to telemedicine access or medication access in general for treating opioid use disorder. I know you mentioned the urine drug screens. Could you talk a little bit about what, if you looked at diversion or the people not taking medications as prescribed?
Let's see, not taking them as, so, that definitely happened. People not taking them as described. I guess I'm not quite understanding the question.
Like, if people had follow-up visits and they had been prescribed medications, what was the sort of loss to follow-up rate in terms of people, not testing positive for bupe even though they're prescribed bupe?
Right. It was all over the map. There's definitely, so we definitely didn't have 100% adherence rate 100% of the time. We do have that data. I feel like it was more like 50%, but and it wasn't adherence for the whole 12 weeks. We were trying to achieve even 8 weeks, but there was many who did like half the weeks. But so that's why when we say success, even just doing it more than once was a success.
Right.
So yes, so there's a lot of so it's a lot of challenges, like I said, still. And
Well, this is a highly vulnerable group of folks, so it's not surprising that, these issues came up.
yeah, and them just finding out that it's an option, like others are saying, that was huge, because in our baseline, only 5% of 200 even knew it was available.
Mhm.
Right.
Medication, yeah.
Ashley, did you want to chime in?
Well, I may have been understanding you incorrectly, but also when you were talking about diversion, do you mean like giving the buprenorphine to other people to use in a way that they weren't prescribed, or were you?
Yeah, that's oftentimes the concern
Yeah.
that people raise.
Um, I I did a lot of like I was doing a lot of the follow-up, and we would obviously the conversations happen with the participants, and I didn't many of them didn't say, they didn't report that, like there wasn't a lot. I got the feeling that there was not a lot of that going on, in terms of like people, they were either taking the medication or not. They weren't really talking about giving it to other people, even though they were sharing other things that were sensitive. So I just personally, that's kind of how I felt, but that's just from my, anecdotal type evidence. So
Right, right. Gotcha.
And the San Diego Library has social workers in there already, or I can't remember. I read the.
Right. We have an internship program that we set up. So they do have 1 or 2 interns every year for at least the 9 months out of the year.
Yeah, you and I briefly discussed that. I tried to get an intern here. The Massachusetts library system was trying to work with some of the colleges up in Central Mass, I think, but we were chosen. But I feel like I would love to be able to get a social worker, even if they, spend some time here and in some of the other Barnstable libraries or Yarmouth or whatever, but so far I get a lot of resistance to that idea from I just funders, because to be able to afford a social worker, I mean, my library staff gets paid crap.
Right.
So,
To do
but
higher.
let's do that.
You may already know this, but social work schools have a requirement for clinical hours for their students, so that's, and they're like, they have to do. And do you know how many hours is it?
It's typically 2.5 days a week for the 2 days to 2.5 days a week for the 2 years.
Yeah.
So they have to do those hours, so that could be another option for free labor, basically.
Yeah.
And, you know, getting
I love
folks.
free labor. I'm a
Getting
library.
folks, well, it's not, I mean, and in this case, you're not exploiting them, you're providing them an opportunity to get their clinical hours.
You do have to have a
Arguably,
supervisor, though. Someone has to supervise them weekly for an hour that has an MSW, so that can be a barrier. So some people pay them.
So,
Oh, there you go,
but board members,
solving problems left and right.
yeah.
All right. Well, I know there was a question from the audience. We're coming to time, but someone asked about the costs. Do you have a sense of how much this intervention costs?
So the social work piece doesn't even have to be part of this, but it would help to have someone there who's a social worker. So without that, just because we were just the researchers, I mean, our role in interviewing and giving referrals ended up being a lot social work. So I wouldn't say we're just doing research, but technically it shouldn't cost too much just having the telehealth, right? But if you add a social worker, then yes, that would be another a role or a cost. And we're just hoping New York is the first state to pass a policy requiring social workers in the libraries. So they just passed that this year. So there was also on a national level, a policy people were trying to pass to have social workers in all libraries.
It's good to require it, but having an unfunded mandate is not a great thing either. So if there's no money for it, it'd be tough.
That's true. Yeah.
Oh yeah, so yeah, I guess Ashley makes a good point that, you know, the social work services can also be provided through telehealth, so you don't have to have necessarily folks on the ground, so. Yeah,
Just a quick question around the urine cups, the pick cups. Was there particular licensing that you had to have in place in order to operationalize that?
The
To-
telehealth, because the telehealth, they're all medical doctors at their clinic. So there's nothing new, that we didn't have any new staff involved. It was just doing telehealth with existing providers who are giving this medication. In terms of us being on site at the library,
drug testing within the library, did that require any kind of compliance issues?
not the urine screening. We didn't do any blood testing. We did urine screening. So
Yeah,
there
the
was
urine screening.
nothing. Yeah, there was nothing that was needed. And the ethics review board, of course, at the university to approve that, but
So like the interpretation of the tests or any of that, or how the data was.
so we read the tests and we recorded them for our research purposes, but they still did the testing at the health clinic. It's just we did it weekly, and so that we definitely would. I mean, the health clinic was wonderful and we had an agreement where they shared us their data on these patients, but we also didn't have to rely on their testing because it could be few and far between.
Right. Gotcha. Does that answer your question?
Yeah, okay.
Yeah, so they didn't rely on ours either, although sometimes they would ask because they weren't getting theirs.
All right. Well, thank you so much, Leanne and Ashley, for this work and for joining us today. It was really exciting, and hopefully it'll be a model that can be replicated elsewhere. And thanks to all of you who joined online and in person. Yeah, thanks for the invitation.
Thank you so much. Yeah, thank you. And we always have lived experience folks on our team. That's really important too. So thank you for bringing that up. Okay, bye.
Thank
Bye,
you.
thank
Bye.
you. Bye.
All right.
Thank you so much.